Hey guys, welcome to the First Principles of Medicine podcast.
In this series, we will be breaking down complex medical topics into their first principles.
When the stress is on and you've been asked a tough question you don't know the answer to,
we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble.
Today we have Jason talking about Cauda Equina Syndrome. Take it away, Jason.
Do you want to introduce anyone first, JT, or not really?
We don't worth his
We've got some
introduction.
special guests today.
yes,
As well.
yes.
We've got Josh here.
Yes,
to
I'm
my
back
left.
again.
Yes.
Back again.
Yeah,
Part of the
I'm
1pm team. I'm looking forward to the year ahead.
Yeah, surprisingly, he's come back again. And we've also got Sim
Hello.
with us.
Good to be the first time on here.
Fellow MD4. And we're going to discuss Cauda Equina Syndrome today.
We passed most of our Oskies here, okay? That's the standard you're getting.
If we're here.
If we're here. You know what? We passed. We're not passed all, but we passed. And I think we did so well that now it's a barrier in third year. So.
Yeah.
Yes.
Yeah. They looked at us and like, oh.
Yeah.
Cool.
But anyway, so Cauda Equina, that's what I'm going to talk about today. And to begin, like all episodes, we're going to go through the first principles. So everyone's favorite topic, anatomy, particularly spinal cord anatomy, okay?
Great.
I know everyone loves their anatomy. So the first question I have, at what vertebral level does the spinal cord end?
T12.
L2, L3.
No.
L2.
See, I'm glad JT got that wrong. So despite all the 1,000 Ankies, he still got the exact number wrong. It's between L1 and L2, okay? So,
So between our answers, we were right.
Yeah.
yeah, so between T12.
Anki. That's Anki.
Close enough, right? It's close enough. Okay, the spinal cord tapers to an end at L1/L2 to form the conus medullaris. And distal to the conus medullaris is a collection of nerve roots. Okay, does anyone know what that's called?
I think you know, Sim.
Cauda Equina.
Yes.
Nice,
Okay.
good job.
Yes.
Wow.
So the collection of nerve roots from L2 to S5 is called the Cauda Equina. Now, Mr. JT, he loves his Spanish. He loves his
I love
Latin. Okay. What does Cauda Equina mean?
So I'll start with Equina. So if you watch the Olympics, equestrian is horse, I believe.
Yeah.
And Cauda, I think caudal, like in anatomy, is like bottom, but it means tail, I guess.
Yeah. So Cauda Equina is translated from Latin, meaning horse's tail, as JT butchered that explanation. Okay. And Cauda Equina Syndrome is essentially a surgical emergency which is caused by the compression of the Cauda Equina. Does that make sense?
Sounds good.
So nerve roots getting squished.
Getting squished.
Surgical emergency.
Surgical emergency.
Mm.
Okay. And like with all causes of any problem, what framework can we use to think of differentials?
Oh,
Surgeons love this.
it's not
The
this.
surgical sieve.
Yes.
I was going to say that, JT.
And everyone's favourite
What is
vitamin.
the surgical sieve?
Vitamin C, D. When does it stop? C, D, E, F?
depends which one, okay? So using the surgical sieve or vitamin C, I think it's like DE now, but anyway, I just remember vitamin C. Can we think of some common causes of Cauda Equina Syndrome?
I'm going to jump the gun and go straight to T and say trauma.
Trauma, yes. So fractures, car crash, you can imagine. Anything else?
I'm going to go for the neoplasm
Yeah.
malignancy.
Perfect. Especially in stages where there's end-stage cancer, where they're having palliative care and bony mets. That's one of the more common causes. Go on, JT.
I guess some like infection or inflammation of the CSF,
Yeah.
causing edema of the area and then compression on the spinal cord.
Yeah. So, yeah, things like osteomyelitis, infections, of course. Can anyone think of any other causes?
Degenerative.
Degenerative, yeah, that's great.
It's what, like spinal stenosis or something like
Yeah,
that? Okay.
vascular spinal stenosis. But the most common cause, I don't know which one you categorize it completely, is disc herniation, which can be caused by a few different things like degenerative or trauma. So disc hernia is the most common cause. But see, it's not too bad to think of if you literally just think of vitamin C, D, E, right?
Yep.
What are the top three causes? Do we have? Or?
I think the number one cause is disc herniation.
Okay. That's
I'd
the
say
only-
disc herniation, trauma, and tumours.
Okay.
And the rest
so
are
we
less
got all
likely.
3. 4.
Yeah.
Yeah. Go team.
Yes.
Okay, so in order to understand the clinical features of Cauda Equina, we've got to go back to the first principles. Okay, we've got to go back to the dermatomes. and the myotomes.
Yes.
Yay!
Said no one ever.
Hear me out, because it really makes a lot more sense if you just understand the dermatomes and the myotomes. So can someone tell me what a dermatome is?
So a dermatome, in my mind, is just an area of skin supplied by one of the sensory nerves.
Yeah, perfect. Myotome?
Similarly, a collection of muscles or a group of muscles supplied by a motor nerve.
Yeah. So myotome, motor, dermatome, sensory.
Yeah.
I don't know why you guys are so afraid of this, mate.
Oh, it's neuroanatomy.
Josh is doing
Josh,
very well.
Josh
Josh is
just-
carrying.
Right, he loves it. Okay. Yeah. So that's great. So as we all know, the sensory nerve can be assessed with a lower limb neurological exam, right? And everyone here are experts in physical examinations, as
Yeah,
we all
we
know.
are.
Especially during COVID.
Absolutely.
We do them all the time.
Yeah, we do them all the time, and we do them thoroughly, okay? Because that's what we strive for here. So I'm going to go through some of the dermatomes, and I want to see whether you can tell me what exact area you would assess. So starting off with S3 to S5.
It's not
Anal play.
Yeah. So Perry...
not what I was going to say.
So S3
I
to
concur.
S5, perianal sensitivity.
Mm.
Okay. L3. What specific part of the body would you touch to assess L3?
Was it thigh?
Thigh's a bit non-specific because I think a few dermatomes.
Inner thigh?
The bottom of the foot.
No.
No, that
It's
So-
either the knee or the inner thigh.
the
So
calf.
L3 is knee. So I think L2
knee.
can be thigh.
Okay,
Yeah.
right.
So
Okay.
L, I should have started with that, but L3, knee.
Okay.
That's just a good way to
Oh, it
remember a
rhymes.
specific area.
I live for that
Three
stuff.
knee. Oh, okay.
Does it? It
Three
actually
knee.
does right.
Yeah,
I didn't
makes
know.
sense.
I'll take that.
L3
Three
knee.
knee.
Okay.
Three
cool.
knee. Okay.
Okay. Now L4. What specific anatomical structure would you touch?
The
I'm-
calf?
Medial calf. Medial lower
Yeah,
leg.
medial. Medial what? What's another structure called medial something? Weber's criteria.
not the medium malleus.
Yes. Medial malleosis, right? So that's an area you can touch.
Malleolus.
What? Malleolus, sorry. What? What did I? Malleolus.
I
sorry.
don't know.
Malleosis.
Malleolus.
I'm getting more malleola.
I've just become a hater now with my mispronunciations. Fuck me. So judgmental. Okay, L4, medial malleolus. Okay? Now L5. Can anyone think of an area?
The plantar surface.
No,
I just said big toe.
It's
I
hard
swear
to
these are
please
like
you.
larger areas instead of that.
I know
one.
they're larger areas, but when you're doing a clinical exam, trying to touch certain
Oh,
areas,
okay.
it's better to remember key points, right?
Okay, fair.
Yep. So a good place to remember for L5 is the big toe.
Okay.
Okay.
Okay? S1, so small toe.
Small? Oh!
See? So to summarize, S3 to S5 is what?
Perianal area.
Yep. L3,
Knee.
Knee.
L4,
The big toe.
No. 5 is the biggest number. so
Oh,
there's
that's the
5
medial.
to-
It's the medial malleolus.
Yes. L5,
The big toe.
S1,
A little toe.
yes. So when you're standing in front of a person's
Mm.
gross leg and you have to touch areas to assess their sensation, I think it's a lot easier to remember specific parts of the body to touch. Okay? Cool. So now, myotomes. Can anyone tell me?
Myotome is a blank to me.
Okay, I'll start you off with L2. It's hip flexion. And think about it logically, it just kind of goes down. So what would be a next logical movement, which would be L3?
Knee flexion.
Knee extension.
Great.
Nice try.
So hip flexion's L2. L3 is knee extension. L4.
Ankle plant. Oh,
Plantar.
Dorsiflex.
L4, ankle dorsiflexion. Okay?
yes.
When you see it in person, it makes a lot more sense. Okay?
Mm.
L5. So when you.
Plantarflex.
No.
Toe big flex.
Yes.
Oh.
Toe big flex.
Big toe flex.
Hallux extension.
We're so good
Okay?
at this.
Yes. S1.
Plantar flexion.
Yes, S1 is plantar flexion. And then S2 to S4, what would that be?
Something with your butt, like glutes.
So that'd be the
No, that
anal
would be
tone.
the hip. Oh,
Okay.
all right, anal tone.
Yeah. So to summarize, the myotomes, okay, the L2,
Hip flexion.
yes, L3,
Knee
Symbol.
extension.
yes, L4,
Keep going.
Ankle dorsiflex.
yes,
Yes.
L5,
Keep going. 5 for the
Hallux-
biggest.
Oh.
I don't know, flexion.
hallux
I'm
extension,
gonna go up.
okay, and S1,
Then you go down. I think.
Plantar flexion.
Yeah.
Exactly.
Ankle plantar flexion. And then S2 to S4, anal tone, okay? So it's also important to know that the Cauda equina provides parasympathetic innervation to the bladder, okay? And that causes contraction of the bladder muscles, leading to emptying.
Sure.
What's
Okay.
that muscle called?
I have no idea, I forgot what. There's a few different muscles involved.
Go on. Take it away.
Detrusor muscle.
Detrusor, yeah, great. The last thing I want you to learn about is that does Cauda equina manifest with upper motor neuron signs or lower motor neuron signs?
I can hazard a guess.
It's a
at
50%
that.
guess. 50-50.
I would say upper motor neuron signs. God damn it.
You chose wrong. Okay. Lower motor neuron signs. And what are some of the lower motor neuron signs?
Hyporeflexor. Is it hypotonia? Yes.
Yep, yep. You also get muscle weakness,
Yeah.
atrophy. So lower motor neuron signs, okay?
Not
Yeah.
upper motor neuron?
Because I thought any nerve coming from after the anterior horn of the spinal cord, that's considered
Yeah.
a lower motor neuron.
And because in Cauda equina, anything from L2 downwards are just a collection of nerve roots as you defined earlier. Therefore, anything below L2 or Cauda equina included must be a lower motor neuron condition.
I think that'll do. So now, let's get through to the clinical features. So when assessing any patient, you first want to do what?
Your A to E response.
A to E assessment, baby.
I'm saying it because Aiden's not here.
Yeah, this is OSCE practice, mate. A to E response, baby. Okay? And what's next?
History and examination.
Yeah. So with the history, I really want to go through thoroughly is the presenting complaint. And what framework do we use?
I would use Socrates.
Socrates, baby. Keeping it simple. I love it. So what's the primary presenting complaint with Cauda equina?
Back pain?
Yeah, severe back pain, right?
I shut myself.
It's not that difficult. Severe back pain, right?
Okay.
That's one of the key features of
All
Cauda equina. Severe back pain with bilateral sciatica.
Okay.
Right, okay.
So once you have that, there may be some other symptoms which are also included. Can anyone think of some of those things?
Weakness.
Weakness, yeah.
Yes.
Lower limb weakness.
Lower limb weakness.
Okay, yeah.
Okay.
So lower limb weakness, it's a lower motor neuron sign.
Because all those myotomes are kind of screwed up, right?
Yeah.
So
Yeah.
L2, 3, or 5.
So lower limb weakness. What else?
Bowel and urinary incontinence.
So to be specific, bowel incontinence, okay? And what would be the cause of that? I'll go through the urinary one as well. So bowel incontinence, what would cause that?
Your anal tone.
Yeah, loss of anal tone.
Which myotomes?
S23.
3, 4, 5.
Yeah, so I think as long as you don't, it's the sacral ones, I guess 3 to 5. That's good. So you mentioned urinary incontinence. What's important to be specific about is that it causes urinary retention.
It's because, as you were saying earlier, in order to pee, you need to contract the detrusor muscle. And when you can't contract because it's hypotonia, then the bladder can't release the urine, so
Yeah.
it has to retain the urine.
And also it's a parasympathetic control.
Yeah.
So
Yeah, right.
Exactly.
Okay,
So
cool.
urinary retention and bowel incontinence. Okay? And we mentioned lower limb weakness as well. Can anyone else think of other things?
Numbness.
Yes. Where? Where
Dermatomes.
specifically?
Over your dermatomes.
What specific area of numbness? It's a classic word.
Perianal
Yeah.
numbness.
Or saddle anesthesia.
Saddle distribution.
Yep, so saddle or perianal anesthesia, and that's caused by a lack of sensitivity in S3 to S5 dermatomes. And the reason why it's called saddle, if you can imagine that you're riding a horse, that's the area where you're sitting on the horse is where you would experience
A lot of horse
a
things.
lack of sensitivity. So everything's related to the horse. The horse is the
True.
first principle.
Ah,
Okay?
I love it.
And for bonus points, can anyone think of a male-specific symptom which may be caused by Cauda equina?
erectile dysfunction.
Yes, great. That's mainly what you have to ask about in the presenting complaint, because the red flag features of urinary retention, bowel incontinence, saddle anesthesia, and lower limb weakness are things you must include in a back pain history, right? Because you've got to rule out Cauda equina. So like with any other history, you go through all the other stuff, systems review, medical history. For medical history, can anyone think of specific things they'd want to inquire about? If you want to relate it back to vitamin C causes.
I was thinking about asking if they're riding horses.
Yeah.
I guess instances of recent trauma, whether that be sporting, motor vehicle accidents, falling off your bike, falling off your horse.
that's great. Yeah.
Recent prostate cancer, breast cancer,
Yeah,
or any
cancers.
cancer, yes.
Yeah.
I guess infective symptoms, if we're kind of thinking about like that abscess formation or
Yeah.
so fever.
So it's not too
rigors.
hard to think of questions when you relate it back to the vitamin C, right? Another thing.
And then the disc hernia. You said that was the most
Yeah,
common
disc
cause, right?
hernia.
Yeah.
Have they had any history of spinal surgeries, right? It probably means
Yeah.
that they've got degenerative spine if they had previous surgeries. Okay, and now going through the exams, right? There are, I think, in my opinion, 3 specific exams you want to do. Okay? Can anyone think of the first exam?
Anal tone.
Yeah, so as we call it, a PR exam, right? And as Sim eloquently said, you want to check the anal tone. So you're going to look for a loss of anal tone. What are the other 2 examinations?
A lower limb examination.
Yes, lower limb neuro. And that's where the dermatomes and myotomes come in. And for lower limb neuro exam, what are some things you want to look for on inspection?
On inspection.
Do they get muscle fasciculation?
Yep, yeah.
So the lower motor neuron stuff that we talked about earlier, like
Yeah.
hypotonia, hyporeflexia, and you said flaccid paralysis, right?
Yeah.
Yeah. They may be in severe pain or have difficulty walking. Okay, in regards to tone, what would you look for?
Hypotonia,
Hypotonia. What about power?
Loss of power.
Yes, reflexes.
hyporeflexia.
Yes, okay. And then the other things like sensation, what would you look for?
Loss of sensation.
Yes. Saddle
Especially
anesthesia
where-
or lower limb
an L4 where-
sensation,
But
right?
but really, it's classically the saddle distribution, but could it not be
Yes.
anywhere? It could also be anywhere else in that kind of dermatome pattern.
Yeah.
Yeah.
Okay, so we've gone through lower limb and PR exam. What's the last one? Think about one of the
Lumbar.
key symptoms, okay?
Urine output.
Urinary retention. How would you assess that in a physical exam?
Kidney exam.
The fucking percuss
percuss the
that
bladder.
bladder.
Yes.
But also blot the kidneys. I might have hydronephrosis or something. Any excuse to say blot, I'll take it.
Genuinely, have any of you guys actually been able to blot a kidney before?
Oh, absolutely. I just,
It's like playing basketball.
I'm not feeling anything. But it's just kind of like,
So you want to perform an abdominal examination because you're trying to feel for a palpable bladder, right?
Oh, fair.
Yes.
Okay.
Yeah, which is a sign of urinary retention.
yeah.
So lower limb neuro, PR exam, and abdominal examination.
Sure.
Okay. So investigations, we've got the bedside bloods, micro imaging, and special tests. But there's one particular test you have to do if you've got a high clinical suspicion that's Cauda Equina. This is like the gold standard test. What would that be?
I'll put my money on MRI.
Yes. So it's essential that you do an urgent lumbosacral spine MRI. And what's another imaging you would consider doing? It could be sometimes considered like a bedside test as well.
Ultrasound.
Yeah, ultrasound. Ultrasound of where?
Of the bladder, right?
Yes. So post-void bladder scan. Because you want to confirm the urinary retention, right? So I think it's really important to know that you need to order an urgent MRI.
Yeah.
That's all I need. All I think I need.
That's all I know.
Oh, that's all I know, guys. That's all I know. You know, my flow's been, this is the first episode back. It's really tough. Dude, cut out this whole
This is going to be
episode,
4
actually.
minutes long, but
Okay. So in terms of management, okay, time is of the essence. And there's only really one management option. What are you going to do?
If he's CDE.
decompress.
How do you just decompress it, right? You can't just give it a massage, right? What are you going to do?
Neurosurge review.
Yes. Early neuro/spinal surgical review, okay? And it's important if you're in OSCE, what are the classic things you have to say whenever you refer to a surgical teammate, whatever?
Do you mean like all your surgical shit? Like,
Yeah.
Oh, so that would
Give
be
it to me.
things like consent the patient, book a theatre room, keep them nil by mouth, chart some pain relief, chart some antiemetics. I want some IV access. I want to take some pre-theatre bloods. I want those coags that grip
damn.
and hold. All that kind of stuff. Maybe an anesthetics review. I don't know.
Maybe.
Maybe.
Oh, damn. Oh, keep going. I'm just, man, that's
Are you gonna book the theater?
I said that,
Oh, you
mate.
did. Okay.
Yeah.
that's
keep the
above
hydration.
expectations right there. That's
IV
a
access
global.
plus minus, IV hydration plus minus O2 if needed.
Mate, give him the 5 out of 5. Give him that surge award right now.
Boom.
I love it.
Mic drop.
The model
I'm
student.
out.
And I'm leaving.
Yeah. So yeah, that's surgical decompression, and remember to talk about the surgical workup.
Jason, I think you're forgetting something. On the ward the other day, when I saw a management of Cauda Equina Syndrome, the consultant was considering using IV dexamethasone, which is a steroid. And the reason why he said to use that was any of those causes, those tumors, the herniations, can cause inflammation in that horse tail region. And if you use a steroid, it kind of helps with the anti-inflammation.
No, that makes sense. No,
Yeah.
I didn't pick that up. Thank you.
Yeah, nice.
Yeah. Think you know better?
You're not the topic master, Jason. Take a back seat.
Okay, so the 3 key takeaways from today, that Cauda Equina is basically comprised of symptoms, which include urinary retention, bowel incontinence, and saddle anesthesia, with severe low back pain and bilateral sciatica. An urgent lumbosacral MRI is the gold standard investigation for diagnosis, and an urgent surgical review is required. Those are the 3 things I wanted you to realise. Do you think you learned that?
Lovely.
Lovely? Yeah.
Amazing. I've been having lots of fun.
Thank you, everyone, for tuning in to 1 p.m. At 1 p.m., it's been a pleasure to have the first episode recorded. We'll see you next time. Ciao.
Bye.
Thank you. Bye.
Everything's related to the horse. The horse is the first principle.
Thank you so much for listening to our episode this week on 1 p.m. Feel free to check out our Anki flashcards and our Notion document. You can also check out 1pm.wiki for more information. We'll see you next time.